Good evening and welcome. I'm James Liu and I'm a librarian at Stanford Health Library. Thank you for joining us for our talk tonight, Understanding Complex Regional Pain Syndrome. It's my pleasure to introduce our speaker, Dr. Vivianne Tawfik. Dr. Tawfik will discuss this pain syndrome, which is a mysterious form of chronic pain that arises after a trauma or surgery on a limb. She will give an overview of this rare but likely underdiagnosed condition. She will also highlight findings from her lab that point to immune system dysregulation as one possible driver. Dr. Tawfik is Associate Professor and Vice Chair of Basic Science Research in the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University. She runs a clinically informed basic science lab focused on the immune contribution to persistent pain while also caring for patients suffering from chronic pain. Throughout the talk, please enter any questions you have in the Q&A box at the bottom of your screen. And then at the end of the talk, Dr. Tawfik will answer as many of those questions as possible. So again, the Q&A box at the bottom of your screen and not the chat box. So the Q&A box, if you want to submit questions. Over to you, Dr. Tawfik.
Thank you so much for having me this evening, James, and the Stanford Libraries for organizing this community seminar. It's such a pleasure to be here with all of you and talk to you a little bit about something that I think a lot about, which is a rare condition called complex regional pain syndrome. So I have no disclosures to share. So I think I always like to start with this slide, which is really just sort of thinking about pain as a concept. And as I was mentioned, I'm a physician scientist, so I spend time both in a research lab as well as seeing patients clinically. But I've also spent a lot of time training. And so jumping back and forth between my research training, my clinical training, it was always really stark how we spoke about pain in very different terms and in very different ways. And so when we think about pain from a research standpoint, we're always thinking about mechanisms. What is it that causes pain? But when we're seeing patients clinically, we often don't actually know what the mechanisms are underlying an individual's chronic pain. And we're often sort of grasping at straws in terms of what treatments to offer them. So I used to think, well, on Mondays, patients would get one type of medicine. On Tuesdays, they would get another type of medicine, but we weren't able to say, when I'm seeing Mrs. Smith in front of me, I am going to give her this medication based on the exact mechanism of pain that she has. And so when I was able to eventually, after many years of training, start my own research lab, my goal really has been to understand the mechanisms underlying different types of chronic pain to be able to really provide more targeted therapies and treatments for my patients. And this is particularly relevant because so many people suffer from chronic pain. It's estimated about 1 in 3 Americans have chronic pain, and about 1/5 of those have what we call high impact chronic pain, which is really pain affecting daily functioning. But what exactly is pain? So again, as a researcher, I might tell you that pain is really something called nociception, and that's really the neurons in your body talking to each other and transmitting information about painful stimuli. And I'll show you a little cartoon in a minute that really gets to that point. But when we say the word pain, the definition is actually much broader. The definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And the word experience is really key to this definition because the experience of pain also includes many other facets that we don't really think about when we're simply thinking about neurons sending information along from the hand, for example, up to the brain. And I'll also come back to that point. So when we think about different mechanisms of pain, we do have to talk to some degree about those neurons that are sending this information. And so in this cartoon, you can see that there might be, let's say, a site of injury. In this particular talk, I'm going to focus on post-injury pain. So in this example, somebody maybe hurts their hand, they fall on an outstretched arm, for example, and that will activate nerve cells or neurons in the hand. that then transmit information to the spinal cord, to this area called the dorsal horn of the spinal cord, where that first neuron will meet other neurons and transmit that information up to the brain, where we have that awareness of pain and where we can say, ouch. But along that whole trajectory of that neuron, there's a lot of other cells that are involved. For example, there are immune cells that are at the site of injury. So if anybody's ever hurt their hand, they would know that it gets red hot and swollen. And what contributes to that symptom is that there are immune cells that go to the site of injury, and they're there to try to fix the problem, but they also do contribute to that swelling and redness and pain sensation. There are also these cells that I'm particularly interested in. I won't talk much about today, but there's these cells called glial cells in the spinal cord and brain, astrocytes and microglia. And those cells can actually modulate the way that the nerve cells or the neurons talk to each other. And then this goes all the way up to the brain, where the brain can also have different representations of pain that are really important. So all along the way, there are different ways, there are different cell types that can be involved in the transmission of pain information. And of course, pain is important for survival. We know that. It is absolutely essential to protect us from tissue damage. So, for example, if you were to touch a hot stove, you would say, ouch, and you would pull away from that hot stove. And that transmission of that painful information from your fingertip up to your brain allows you to not get burned, or only get a little bit burned, hopefully, before you have the reflex to pull back. And we know in these rare cases where patients have no pain, is called congenital absence of pain, that they actually have really significant problems in life, and they actually tend to die quite early. And there's this one example from this paper a few years ago where it came to medical attention that there was this boy who was basically a street performer at the age of 10. He was able to do all of these, really kind of fascinating, but also scary tricks where he could walk on hot coals, he could put, sharp things into his arms, and he had no pain. And through studying this boy and then sort of tracking back through his family, and what that looks like is this example here is that here's the boy. And if you track back through his family, you can find other cases, including some cousins of his who are also colored square in a circle here in black, where they also had this particular insensitivity to pain. And with all that, they were able to map it to a very specific part of one gene on one chromosome of the body. And that was something called SCN9A, or a sodium channel that is located on these neurons that I was already talking about. And that one mutation, that one sodium channel, resulted in this person not being able to transmit painful information from the site of injury up to the spinal cord and ultimately to the brain. So we know that that's a problem. We don't want people to have no pain, but we also don't want people to suffer for years and years with chronic pain. So we know acute pain is important, but is chronic pain really just acute pain that lasts longer? So you have, you break your wrist, it hurts, it's supposed to hurt. We know that it's hurting because, there's healing happening, and initially that's okay. But really, when does that become chronic pain? And so by definition, chronic pain is actually just acute pain that lasts longer. And actually that longer, depending on the type of pain or injury, is usually thought to be around 3 months. So if you look at definitions of chronic pain, it's pain lasting longer than 3 to maybe 6 months. And if we just sort of think about the mechanisms and the underlying sort of basics of acute versus chronic pain, there are things that we can learn in addition just to that time period. So as I already mentioned, in the case of acute pain, hurt equals harm. You touch the stove, it's painful, you're going to pull back. Avoiding that pain is going to improve your chance of, survival and less harm. But in the case of chronic pain, it's not always the case that hurt equals harm. In fact, many of our patients who have chronic pain are encouraged to work through pain, depending on the pain syndrome, and actually engage in activities that they otherwise would be avoiding. And sometimes that avoidance can actually worsen the problem. And that causes what we call a fear avoidance cycle, where a fear of doing certain activities leads to more compensation from uninjured parts of the body and therefore more pain. When we think about the cause of acute pain, it's usually pretty obvious. You can, see a broken leg, or you can see a swollen ankle, something like that, and you know what happened. But with chronic pain, there isn't always something you can see clearly, and I'll come back to this. The physical exam isn't always telling. And it's really often a multifactorial disease where we also sometimes can invoke the biopsychosocial model, or really thinking that there's many aspects that come with a chronic pain syndrome. And then the treatment. So again, if you have a fracture and it heals, then we'd consider that to the end of the treatment for acute pain. In a lot of cases, actually putting a cast or some sort of immobilization of the limb can be helpful. And when we think about that in terms of chronic pain, it's often the opposite. There's maybe no fixed endpoint. We might not know the underlying mechanism. So we can't say that we've cured it or it's resolved because we don't know exactly what we're treating. And as I'll talk about, sometimes immobilizing the limb or putting a cast on it can actually worsen the condition. And there's really the key is in our clinic, we're very lucky at Stanford to have access to multidisciplinary care, which I'll speak more about. So as I said, chronic pain has many facets. We do invoke this biopsychosocial model, and it's more than just neurons sending information along from the finger to the brain. So we can think about that aspect, which we sort of think about as sensory discriminative, so the intensity or the location or the quality of the pain. But then there's also this aspect we call affective motivational. It's unpleasant to be in pain. We want to escape our pain. It's negative. And that's sort of brought in by our brain and multiple brain regions that add this sort of negativity to pain. And then there's what we call the cognitive evaluative aspect, is that past experiences, either something related to when the injury happened, for example, getting hit by a car, and then you have sort of that connotation. And so that brings in memories and anxieties that can be associated with the pain that became chronic. And I, again, have a, as a basic scientist mechanism person, I often will have these conversations with some of my, basic science non-clinician friends, and I'll say, well, if pain is not negative, then is it a problem? And it's something you can sort of think about as we sort of go through and talk about these different aspects of pain. But I think it is something that negative valence of pain is really important. So as I said, when is acute pain no longer acute pain? When does pain become chronic? And in the case of an injury, which is really where I'm focusing my time, which is really my expertise is chronic post-injury or post-surgical pain, it's really all about trajectory. Patients should be improving, not worsening in the weeks after an injury, a surgery, or a trauma. And so I often will give lectures to surgeons who are seeing, many, many patients with the same diagnosis, performing the same surgery many times over. And they'll say, well, how do I know that this patient should come see you? And my answer is, you've done 1,000 carpal tunnel releases. And if you know that 6 weeks after the carpal tunnel release, your patients are normally back to gardening or cooking or whatever it is they enjoy doing. And then you have a few patients who just don't seem like they're right back where they should be. Those are the patients that I want to see. Those are the patients I'm going to worry about and who I want to start to think about might be developing into more of a chronic pain syndrome. It's all about the trajectory, and the trajectory can be different. There's some injuries or surgeries that take months or years to heal. There's some injuries or surgeries we know should take more like days to weeks. So when we think about chronic post-surgical or post-injury pain, as I am trained as an anesthesiologist and a pain management physician, we really sort of think about that as pain that lasts greater than 3 months after surgery, localized to the surgical site or an area nearby. And then we've definitely excluded other causes. So if somebody has an active infection, we wouldn't really consider that chronic post-surgical pain. It is different in character than what brought the patient to surgery. And that's often a question I'll ask my patients. They'll say, oh, I, twisted my ankle and it hurt, but, I was kind of walking on it, but then I went and got checked out. And it turns out, that actually I had this fracture. But then after the surgery to fix the fracture, my pain just skyrocketed. It was 10 out of 10. And so it's this sort of change in the pain presentation or the quality or the severity of the pain that sometimes can be a clue to what is going on with that individual and with their pain. And depending on the type of surgery or injury, it can actually be a very high prevalence, so up to about 1/3 of patients, depending on the type of injury. So just thinking about orthopedic procedures, which are obviously extremely common, many people have different types of injuries or need surgeries for their bones. So for total hips, for example, about 7 to 23% of patients have long-term pain based on 6 studies. When we're looking at total knee replacements, it's even higher. Up to 34% of patients can continue to have long-term pain after a knee replacement. And sort of the classic one I think of is that fall on the outstretched arm and breaking the distal radius of the wrist. And up to 30% of patients can have pain at 1 year post-injury. So it is very prevalent to have these sort of post-injury or post-surgical pain syndromes. But even within that group of post-injury or post-surgical pain syndromes, not all chronic post-injury pain is the same. And I use this image as an example, and you can clearly see that these 2 feet don't look the same. And this is a patient of mine who, when I first started seeing her, was very young, and had just had simply twisted her ankle. And she ended up with this persistent red hot swollen foot, which you can see in the picture is completely abnormal. And what she had was this type of or subtype of post-injury pain called complex regional pain syndrome. And complex regional pain syndrome is this form of chronic pain that can occur after even a mild injury. So in the case of my patient that I just showed you, it was just after twisting her ankle, which, I'm sure many of us have done many times, over the years. What's particularly interesting about CRPS is that it really presents with pretty clear visual symptoms. And so I show here the different categories that are used for diagnosing CRPS. They're called the Budapest criteria, and they were developed about 15 years ago. And you can see in the different categories, these are patients who come with pain, often not just pain, but actually touch sensitivity, which is pretty unique and unusual. Not many patients with chronic pain have touch sensitivity, but with complex regional pain syndrome, that is something that we often see. They have what we call pseudomotor changes, so swelling and sweating changes. They have vasomotor changes, which are basically temperature change and color change. And you could see redness in the prior picture, but also patients sometimes report mottling, blue, purple, and sometimes even changes throughout the day where, it might be blue in the morning and redder in the afternoon. And then what we consider to be the motor symptoms, loss of range of motion. So going back to the wrist, difficulty with extension or flexion. They might have a tremor in that injured limb, weakness, difficulty with grip or with, going on their toes if it's a lower extremity injury. And then we also see hair and nail growth changes. So I'll often ask patients, do they notice that their nails grow faster or slower on the injured side? Do they have a change in the hair growth on their injured limb? I did receive some questions in advance, and one of the questions was, is there really like a very specific diagnostic criteria for CRPS? And this is sort of the checklist that we use that's based on the prior slide, where a physician can diagnose CRPS based on these Budapest criteria, and they have to see 2 or more signs or patient reports 3 or more symptoms. It's not perfect. I mean, just to be honest, almost my entire practice for the past 10 years has been focused on patients who either have complex regional pain syndrome or wonder if they have complex regional pain syndrome. And I can tell you that every patient meets criteria differently, and every patient is unique in their own trajectory of pain and recovery. And so I think this is sort of the best that we have right now for CRPS. These diagnostic criteria were actually really based more on research studies and wanting to be able to, bin patients in a certain way. So again, not perfect. And I personally think that CRPS is very different. Every patient who presents with it, it's like, I always say they're like unique snowflakes. Everyone is a little bit different. So it does take some getting used to and, seeing many patients with CRPS to be able to kind of pick up on that. And as I'll say again and again, I just think this is a really under-recognized condition. And so patients who may meet criteria go undiagnosed for a very long time. Now, another way you could diagnose or sort of think about CRPS is in this kind of cause-based or etiology-based diagnostic criteria. And so sometimes people will talk about CRPS type 1 versus CRPS type 2. So CRPS type 1 is without a known nerve injury. CRPS type 2 is with a known nerve injury. And as I'll tell you, if I have time later in the talk, I think most people are actually CRPS type 2. It's just that many of the practices don't look for the nerve injury because they don't have the means to look for nerve injury. So most of what people are doing is saying, oh, well, you don't have a nerve injury because you didn't have a surgery on that nerve. But in fact, many patients have a nerve injury that is just unrecognized. So I think a lot of people who are diagnosed with CRPS type 1 actually, in fact, have CRPS type 2. Another way we can think about CRPS is by their phases. So there's this idea of sort of acute, and I've been talking a lot about, well, what's acute pain versus chronic pain? And so the same thing with CRPS, it's sort of an example where we see this acute phase of CRPS, which I think of as like red, hot, and swollen. It's kind of what you expect after an injury. And if you catch people during that early phase where they still are red hot and swollen, they do tend to be more responsive to treatment. But after they become what we call more chronic CRPS, the limb itself might become cooler, maybe shrunken, or atrophic is the medical term. And if you were to look in the spinal fluid, you would see that the inflammation is now in the spinal fluid, as opposed to inflammation being at the level of the injured hand, for example, where you might find inflammation in the more acute phase. This is not 100%. And this is why I'm saying it's so hard with CRPS, because some patients will transition from the acute to chronic phase, usually within the first year after the injury. But some patients stay red hot and swollen for years. And some patients, right after the injury, become cool and shrunken in the limb. And so it's definitely not perfect sort of thinking about the phases. But if you take all comers who have a diagnosis with CRPS, the longer you have it, the more likely you are to be in this cool central phase, what we call central phase. And so I think that's just, again, another way to think about it, and another way to sort of, as we're thinking about mechanisms underlying pain, it allows at least me to sort of rationalize different treatments that I might suggest to a patient. So I just told you a lot of these patients come in and they're red hot and swollen. And that is totally normal. If you've ever broken anything, or you've had kids who have broken something, it gets red hot and swollen after injury. And those are sort of the classic signs of inflammation that everybody learns, the first day of medical school: red hot, swollen, painful. Totally normal. But again, it's totally normal in that initial phase after the injury, but it's all about trajectory. So you should be getting better, not worse, in the days, weeks, months after the initiating injury or surgery. So when I think about CRPS, it isn't that common, as I've said, and as was said in the introduction. It only occurs about 50,000 new cases a year, but I really do think it's under-recognized and underdiagnosed. And I think part of that is the fact that it looks like inflammation. And so if you have an injury and it's red hot and swollen, and then you go back to medical care and it's still red hot and swollen, a lot of times the provider will say, well, red hot swollen, that's what it's supposed to be. Inflammation is doing its thing. That's what it's supposed to do. But again, it's that time course. And as the individual patient, you're probably thinking, wow, this has been red hot and swollen for a very long time. But maybe that provider is seeing you for the first time. So they don't have that kind of continuity to really see that it hasn't changed or it's getting worse over time. So I think as a result, a lot of patients go undiagnosed or underrecognized. And that's also why I like giving these types of lectures to the public, to sort of bring more attention to the fact that, this is something that happens. I think with higher frequency, it's just that we're not catching on. And the earlier we can catch these sort of off trajectory patients, the better we can do to help them get, to get treatment and to recover. So there are some known risk factors for the development of CRPS. Unfortunately for my gender, females just have a 3-to-1 likelihood of CRPS, and many pain conditions are more common in women. So that is something to consider. It's probably obvious by now, but a history of trauma or surgery is a predisposing risk factor for CRPS. There are genetic underpinnings, and I've already said, but every patient with CRPS is a little bit different. And there are some types of presentations that are, I think, more linked to underlying genetic abnormalities. And then there's this concept of cast tightness, and I'm just going to spend a moment on, because I think it is really important to think about. And again, in terms of like thinking about what is important for public dissemination and education, there were some studies that came out that I'll tell you about where this concept of kept feeling like your cast was too tight was a risk factor for developing CRPS. So sometimes I think about this as like the chicken and egg situation. Is it that the person placing the cast places the cast the exact same way every time, and that the individual got more swollen than expected after the cast was placed? Or did the individual placing the cast actually place it too tightly? And I don't actually know the answer to that question. My sense is, with sort of watching many patients over time, that probably the swelling was more extensive than expected. But the key is, if the patient feels the cast is too tight, then the answer is we will cut the cast off and try again. And that is really important. And again, that is something that I try to educate like our emergency department on, the orthopedic surgeons who are involved with this type of casting, and others, so that they can recognize that when a patient comes in and says, oh, this doesn't feel right. I've had casts before and this one just feels too tight, that they can actually do something about it. And so, just very briefly, this came out of a study that was done for a totally different reason. It was actually a study done 25 years ago now, looking at whether or not vitamin C would improve CRPS. And I'm not going to get into it, but there's this term reflex sympathetic dystrophy that is used for CRPS in the past. And what they found was that, unrelated to the vitamin C question, that if the patient complained, and you can see there's complaints in plaster, it was a European study, but we'll just call that a cast. So if the patient complained that the cast was too tight, they had 67% of them develop CRPS, compared to 18% did not develop CRPS. So right away, it looks like somehow that complaint of feeling like the cast is too tight increased the risk of CRPS. And then this group went on to study more vitamin C. And what they found was that actually feeling like the cast was too tight increased the risk, we call the odds ratio, so the odds of developing CRPS, by sixfold, almost sixfold. And so really it is an issue when that cast feels too tight. Now, I'll incidentally mention, because I have the slide up here, that in terms of prevention for CRPS, vitamin C can be a good preventive measure for CRPS. So if you end up with a fracture and you have no other reasons that you can't take vitamin C, if you look here, taking 500 milligrams of vitamin C a day, and this is from the start of when the fracture happens for 2 months after, it decreased the risk. So now there's a fractional risk of developing CRPS down to 0.14. So that's actually quite a significant improvement when you take vitamin C 500 milligrams a day. So if you're looking for something just so simple, and you probably have lying around your house, or you can go buy it at CVS, just taking vitamin C after a high risk injury is protective for the development of CRPS. So we've talked a little bit about sort of different types of post-surgical or post-injury pain, but how do we actually diagnose and distinguish when we're seeing one type of pain or another? And this is something really important because, we want to, as I said at the beginning, as a scientist, I want to provide mechanism-based therapy. I want to have a patient in front of me and I'm giving them the treatment that is right for their type of pain. But a lot of times we don't have that ability. We're not able to diagnose something very specific. And so we can do a lot of things, though, to try to get at that answer. So one is obviously taking a good history. And I think, honestly, I always say the patient is telling you the diagnosis. Like, if you have the time to listen to the story of how it started and how it happened, there's a lot of information there. And sometimes the patient doesn't even realize, like, okay, what exactly happened? And where were you? And how were you standing? And how did you fall? And all of these things that maybe they've forgotten about even. But then it all kind of clicks together and it makes sense for what could be causing their pain. There's certainly a physical exam, and those went away a little bit with COVID, but now they're back. But physical exam can be telling, or as I said before, sometimes with chronic pain, it's not obvious what the physical exam is showing. We can do something called diagnostic blocks, where we actually do injections to numb up certain nerves, the way you would get numbing medicine like at the dentist's office. And in doing that, we can look and see if a specific nerve is involved in a patient's pain syndrome. We can do nerve conduction, or EMG, which can actually measure how the nerve is sending information up and down, from the hand to the spinal cord. And we can do imaging. And I'm going to spend a few minutes now just talking about an imaging study that we did here at Stanford with some colleagues of mine, because I think it's kind of a new way to think about imaging pain. So how can imaging help with diagnosis? Pain is subjective. I told you already, it's an experience. How do we measure an experience with imaging? And I think it's really important to think about both the definition of pain as an experience, but also nociception, or that transfer of information along that neuron, along that nerve cell from the fingertip to the spinal cord and up to the brain. And that nerve cell we can image. And there are a lot of different nerve cells, though. And so, how do we really get at imaging them in a way that allows us to understand better what those nerves are doing? And not just that, I already talked a little bit about CRPS type 1 versus type 2, but how do we figure out if somebody has an injured nerve? And if they do have an injured nerve, that might actually focus down our treatment or allow us to provide a mechanism-based treatment. So I was lucky enough a few years ago to work with a very talented radiologist named Sandeep Biswal, who is at Stanford. And he introduced our clinic to a technique called MR radiography, or MR neurography, which is really an approach to see pain. And there's a lot of details here in the slide, which, if there's some enthusiasts out there who are interested, it's worth reading. But essentially the concept is this MR neurography allows us to really image the nerves after they exit the spinal cord. And let's say, again, using my example of hand, because it's what I can show you on the screen, that if somebody has pain in their hand, we can image at the wrist and we can look at the nerves as they come down the arm and into the hand and see if there's any pinch points, see if there's carpal tunnel, even though they've had a carpal tunnel release, and yet we still see that nerve is squished in some way. And so this technique allows us to see entrapment of nerves, lesions on nerves, tumors pressing on nerves, things like that. It does require expertise, and this is where, the advantage of being somewhere that is very interdisciplinary, like Stanford, with lots of experts in different domains, because these nerves are teeny tiny. And you really have to work with somebody who's willing to kind of go back and forth with you and talk through, what you're looking for in these scans. Even the sciatic nerve, which many of us think of as this huge nerve in the leg, is only just 7 millimeters. So it's tiny. And many radiologists don't have experience with this technique. But what can we actually see with it? So these are, again, technical details, but the point is, if you look here in the cartoon, this is a normal nerve. It just kind of looks gray and boring, like a bunch of gray spots in a circle. But in a nerve that may be injured or compressed or have some sort of, problematic injury to it, you can see that the nerves get bright, they get white, they get swollen, and those are all things we can see with this type of scan. So we did a very simple study through this interdisciplinary group that I'm part of. We call ourselves the Nerve Team. We're sort of like pain superheroes. And this interdisciplinary nerve team gets together every few weeks and we talk through complex patient cases. And so it's myself and a couple of my colleagues in the pain clinic getting together with some of our peripheral nerve surgeons, as I've already mentioned, radiology, neurologists and physiatrists who do EMGs with us, and then our physical therapists and pain psychology colleagues who are very integral to our pain management clinic at Stanford. And so what we did is we actually just looked at patients who came to us either through my clinic or through the hand clinic, and who were evaluated using this special technique, this MR neurography technique, and who we discussed at this conference. And then we looked to see what happened with these patients. Did we discover anything new? And what we found was actually quite striking. So when we looked at the patient's scans, we found that a large majority of them had very distinct changes on their MR neurography scan. And keep in mind, these are patients who are seen at Stanford. So they've likely already been seen by many physicians elsewhere. They've been having their pain syndrome on average 9 years in this particular study. And many of them were told that, we don't really know what's going on. And in this case, we saw 60% of people had a signal change. So that brightness that I showed you in the little cartoon on their scan, or they had a change in how thick or thin the nerve was. So meaning maybe it was getting compressed or deviated or something else or disrupted. And so we were actually able to pick up something on about 2/3 of patient scans, which is quite striking, again, for a group that, generally speaking, has not had a very specific diagnosis. And this is just an example. I know it's hard to sometimes look at these scans if you're not used to them, but they're the same scan on the left and right, just with a different type of imaging parameter. And I put some labels on it, and this is basically looking at the elbow here. And so what we're looking at is the nerve of the elbow called the ulnar nerve compared to the nerve that kind of runs up the middle called the median nerve. And they're side by side on this scan. And what you can probably appreciate is that the median nerve is very gray, just like I showed you in the cartoon before. But the ulnar nerve is very bright and very white. And I can tell you, it is huge. It is not supposed to be this big. And around it, there's swelling of the muscle and what we call fibrosis or scar tissue sort of below it. And so again, this is a patient who previously had surgery and was told, no, your nerve is fine now. There's nothing more we can do. And then we did this scan and we were able to pick up on the fact that the nerve was not fine. And actually, it was quite abnormal at this level where they thought that they had fixed it. So this is quite telling when we're looking at these images. The other thing that we found was that we were really able to actually change diagnosis for these patients. So I have here on the left side what diagnosis the patients came to us with, and on the top, what diagnosis they ultimately ended up with after we did this interdisciplinary evaluation with the scan, with the MRI. And you can see that CRPS type 1 was quite common, but many of these patients after evaluation were now diagnosed with CRPS type 2, meaning that we thought that they did not have a nerve injury, but in fact, when we looked for the nerve injury, we found it. And so we shifted them from this, kind of more nebulous category to a more specified category with a mechanism to it. And then this NOS means not otherwise specified, which essentially is kind of another CRPS type 1 diagnosis. And again, 4 of those patients ended up moving to a known nerve injury category. And so in total, about 70% of our patients shifted from a more sort of non-specific treatment category or diagnostic category to something that was more specific. And so with that, we sort of, concluded that this interdisciplinary team using this specialized MR neurography technique really allowed us to get more at a specific diagnosis to be able to offer specific treatment. So now, I've sort of said all this about what is post-injury pain and what is CRPS and how can we diagnose it or how can we be more specific in our diagnosis, but then that leads us to treatment. And so what does it actually mean to treat a patient with complex regional pain syndrome? And so I'll just start by saying that it absolutely needs to be multidisciplinary. So there are medications that can be used, which I'll speak briefly about. Physical therapy or hand therapy, occupational therapy is absolutely integral to CRPS treatment. And this gets back to one of my first slides, which is that in the case of CRPS, avoiding movement can actually worsen the syndrome. And that is very difficult because these limbs, as I said, are touch sensitive. I mean, who wants to move a hand when it hurts just to have air on it? It's extremely difficult for patients to move their limbs. But we know that the more the limb is not used, the worse the syndrome gets. Education about CRPS is extremely important. We also use our pain psychologists in our clinic a lot. There's this whole connection, I didn't even show you in the cartoon, of the brain that can suppress pain at the level of the spinal cord. So engaging those pain suppressing mechanisms using pain psychology, active interventions with pain psychology can be extremely helpful. And then interventions such as nerve blocks that I briefly mentioned, spinal cord stimulators, other things, other ways that we can get at specific nerves. So there are many medication options for complex regional pain syndrome and for other types of pain. And there is a lot of overlap between those. And this is where I think understanding the mechanism underlying an individual's pain is particularly helpful. I'm generally a risk-averse person, and I'm risk-averse on behalf of my patients. So I don't want to suggest something unless I think it's worth that the benefit outweighs the risk. And as a result of that, I like to really think about what might be the right option given where they are and what the potential harms could be. So I'll just go through a couple of these because I know there were some questions submitted prior about the benefit of some of these potential treatments. So if we think again mechanistically, like what is the cause of the person's pain who's coming into the clinic? When we think about, and I put the little cartoon there, this inflammation or this peripheral sensitization. So we have that inflammation there. It's supposed to be there initially. We need it there initially to be able to heal whatever the injury was, but we don't need it to stay there forever. And I sort of think about CRPS as like exuberant inflammation. Like the immune cells came in, they did their job, and they just didn't go away. And what we do with steroids then is that it's like a big hammer. It just sort of suppresses all of that inflammation so that it can resolve. And then hopefully not just resolve the inflammation, but also resolve some of the swelling. And then we can sometimes get a feed forward where less swelling equals better movement equals less swelling, less pain. And then we can kind of, intercept on this sort of negative cycle that often happens when there's a lot of swelling and pain. So steroids tend to be most useful during that early acute phase that I talked about, that red hot swollen phase, which again, roughly is within 6 to 9 months of the initial injury, but everybody's different. So, just to keep that in mind. Now, the other thing that gets a lot of press and a lot of conversations, I think, on patient channels when we're thinking about CRPS is this category of medications called bisphosphonates. The most commonly used one, or the most known one, is Fosamax or alendronate. And this was based on some data from several studies in the early 2000s where they showed that treatment with these bone turnover medicines could be beneficial in patients with CRPS. And again, the concept here is partially perhaps helping the bone strengthen if there was a fracture, but also this category of medications or bisphosphonates also target peripheral inflammation, and they decrease peripheral inflammation. And so we do think that they do have some benefit. And there was a study in Europe using what's called neurogranate in Italy, and a lot of people I know have gone to Italy to get this treatment. In my experience, using an oral medication equivalent called alendronate for 8 weeks is just about the same as the IV neurogranate that they were using in Italy. Now, the problem with the neurogranate is that they did repeat a study here in the US about maybe 5 or 6 years ago now. I can't remember exactly. And the data were pretty negative. And so that study ended up being terminated early. So I don't exactly know what happened with the study here, but I still do think that this is a potentially good option, again, for the right patient where I'm convinced that this might be helpful, because these are riskier medicines than some of the other medicines that I'll talk about. There's a lot of excitement about ketamine. Over the past few years, the potential for ketamine to be helpful in depression has made a lot of news lately. Ketamine has been used for the treatment of CRPS for many, many years. And again, thinking about the mechanism, we think it probably works on this first communication with that neuron that comes from the hand that goes to the spinal cord. And that communication from one neuron to the other before it goes up to the brain, or even once it's in the brain, is a potential area where ketamine can kind of calm the signal. So sometimes we think of it as sort of like a reset to sort of decrease that excitation or inappropriate excitation of all the nerves as they're sort of, signaling to the brain. We have sort of 2 protocols that are in the literature. One is what we call an inpatient protocol, where a patient will come into the hospital and get an IV, and they'll actually get a continuous infusion with ketamine for about 5 days. And then there's the more commonly used outpatient protocols, where they're about 1 to 4 hours of IV infusion, sometimes repeated multiple days in a row, sometimes just once, and sometimes that's called a booster. One thing to keep in mind is that doses that treat depression are generally lower than the doses that are used for chronic pain. So a lot of what we see in the news is sort of these one-time 45-minute infusions of ketamine for mood, and those generally are not quite enough to like reset the system as we think about for ketamine for chronic pain. So my own sort of totally anecdotal, but over many years of treating patients with ketamine, is that about a third have no improvement at all. About a third have improvement while we're running the infusion, but once we turn it off, that improvement goes away. And about a third of patients will have a lasting improvement. And what we consider lasting is on the order of months to years. And those are the ones that's what we're aiming for, is we want that really long-term improvement, because it is disruptive, come into the hospital for 5 days, be hooked up to an IV. It's not something you want to do with frequency. And the other thing, again, totally anecdotal, is that patients who ultimately get the most benefit tend to be the ones who need lower doses. So when we're pushing the doses really high, a lot of times that isn't helpful. when I was a medical student training, they used to do ketamine comas where we would bring patients into the intensive care unit and just completely sedate them. And it was extremely dangerous. And we absolutely do not do that anymore. But again, it's always about risk benefit. And, at these low doses, I think for many patients, the benefit is there at much less risk than those high doses. And then there was a submitted question about topical creams. And I have used ketamine in a topical cream that I have found to be useful for patients. Generally speaking, topical creams are not covered by insurance, so they can get pretty pricey depending on, how they're made and the compounding costs. But ketamine in a topical cream can be useful, applied to the limb that's injured. I'll just briefly talk about sympathetic blocks. This is a concept of CRPS, which is essentially that there's this hyper overactivity of the fight or flight nervous system. So not just those neurons that are sort of connecting, as I've spoken about, but the nervous system that's like if you're being chased by a bear, that's the system that helps your heart rate go up, allows your eyes to dilate. We don't need that system activated when we're just watching TV. But for patients with CRPS, that nervous system, that part of the nervous system can be on hyperdrive. And so there are ways to tone down that part of the nervous system using what are called sympathetic blocks, using local anesthetic into either an area of the neck where those nerves are located if it's a hand injury, or into an area of the back if it's a lower extremity or leg injury. Unfortunately, when you look at all comers in terms of, whether or not there's evidence to support the use of this particular treatment, it's not great. The data are not very supportive of the use of this particular intervention. But I have, in my experience, had some benefit when I do sort of a series of 3 of these blocks a few weeks apart. Again, anecdotal, and most of the data is not very supportive for the use of these sympathetic blocks. I just want to speak briefly about this sort of, out there thing that has come from some of the research I've done in the lab. And it's also thinking about another mechanism of CRPS. And that's, again, I was talking about this inflammation or like the swelling. One other aspect of inflammation is what we call our adaptive immune system, which is approximately the B and T cells that you might have heard a lot about in the news, because CAR T cells are now very big in terms of cancer treatment. Well, B cells make these things called antibodies, and those antibodies can be very beneficial in many cases. But if those antibodies are actually attacking self, then that's a problem. And that's what we call autoimmunity. And there are many autoimmune diseases like rheumatoid arthritis, lupus, where the body is essentially attacking itself through these B cell antibodies. And there's some evidence to support the idea that CRPS may also have these autoimmune mechanisms. And so through working with one of my colleagues, Ian Carroll, we started to actually think about that autoimmunity as a potential target for CRPS. Again, we were using some autoimmune type approaches like steroids, although that was kind of just squashing all inflammation. But the medication hydroxychloroquine is something that's used for rheumatoid arthritis and lupus. You might also have taken it preventively if you were going to somewhere that has malaria endemically. But hydroxychloroquine is used as an immune suppressive for autoimmune conditions. And so we actually did a small retrospective study where we started to give patients hydroxychloroquine who had really refractory CRPS. And so this is just a summary of the patients who were in this study. So there were 7, they're all women, and they'd all had CRPS for many, many years, 2 to 25 years. And at the time of the study, they were taking CRPS, some for a very short time, some for many years. We published the study in 2020. I can tell you most of these women are still taking hydroxychloroquine. And we just very simply looked at their numerical rating scale. So what's your pain from 1 to 10, either before they started the hydroxychloroquine or after. And we saw a significant decrease in that numerical rating scale, both on average and with any exacerbation. And so that was exciting. And then the other thing that we saw, and this is just an example of one of our patients, where pre-treatment, you can see this color change, the modeling, the kind of like swelling and doughiness of the limb. But after treatment, it had really significantly improved. And we went on to do a paired preclinical study using a model that we have in the lab. And we were able to replicate these findings, which was really exciting, showing that we really felt that, that these patients were going to get benefit from this anti-autoimmune treatment, which again is very different. So with all that, I think I've hopefully convinced you that the mechanisms of pain are complex, the mechanisms of CRPS are complex. As I see patients, I try to think through these different mechanisms to be able to start to hone in on specifics that may allow me to make, I'd like to think, a more educated, suggestion in terms of treatment plans, which again are always multidisciplinary. I'm also lucky enough to run a research lab that is very focused on the mechanisms underlying chronic pain. I say I have this tagline, rigorous science done by passionate people, because I do really believe that, it's the people who do the science and who really make it great. And we really enjoy sort of thinking about chronic pain and thinking about ways we can come up with mechanism-based therapies. And so I coined this term, clinically informed basic science. And so really taking what I see in the clinic and then bringing that to the lab so that what we do in the lab is relevant to my patients. My goal is really to be able to provide that mechanism-based care to patients, not just those who have CRPS, but those who are coming in with any sort of chronic pain. So hopefully with that, I've convinced you that chronic pain, it's complicated. CRPS occurs in the limbs, often after a minor trauma. It can look like usual healing, but it's off trajectory in some way. And really multidisciplinary care is key, and mechanism-based care is key. And I just want to briefly shout out to my nerve team, who are all the people seen here. More recently, it's really been Catherine Curtin Page Fox and Sarah Sakamori, as well as Dr. Pedersen from radiology, Raymond Chow from physiatry, and Einar Odesat from my clinic as well. And so with that, I will just say that I do think mechanism-based, targeted, and interdisciplinary care for chronic pain is really the future. So I think there are some questions, and thank you so much for everyone's attention. And it looks like there are a lot of questions, so I'll try to run through as many as I can in the minutes that we have. So the first question is, if you had CRPS and it went away, what is the chance of recurrence? And it's a really good question. I always consider that somebody who had CRPS in the past is at increased risk. There is no question that they're at increased risk with any sort of subsequent injury or surgery. But if it got better, that proves to me that that body knows how to heal, and that it's likely that it would be the same in the future. That doesn't mean that I don't do what I call risk mitigation. So if I have a patient who had CRPS who then is going in for another surgery, then I might say, okay, look, we're going to start vitamin C. We're going to get you on the medicines you were on the last time. We're going to make sure that, that we talk to the anesthesiologist in advance, that we talk to your surgeon in advance. So we think about all of these things so that we just try to minimize the risk as much as possible. So while it's definitely higher risk if you've had it in the past, it's not 100%. And I have many patients who had CRPS who went on to have very successful subsequent surgeries and no issues the next time around. So there was a question on topicals. I think maybe I answered that one. I think ketamine topically is helpful. Sometimes I'll add, lidocaine or a local anesthetic topical to it. And I think that often is helpful. The more things you add, the more expensive that tube is. So if I was just going to put my money on one thing, it would probably be a ketamine cream. The treatments, I think hopefully I covered that because that was a question asked earlier than my treatment section. Can peripheral neuropathy be a criteria for CRPS? So this is where it's like a little bit complicated, and the diagnostic criteria are not great. So CRPS type 2 requires that known nerve injury. So if there is a peripheral neuropathy that's known, then you would consider it to be CRPS type 2. But if it needs to also have something else. It needs to also have some of those additional findings. So either like red or swollen or tremor or something else. So the peripheral neuropathy on its own does not make the diagnosis, but can sort of hone in on the diagnosis. Okay, there's some questions about, having had CRPS for a long time. So first of all, I just want to acknowledge how many people on this call are probably dealing with exactly what I was talking about. And so I think there is potential for treatment. Many of the patients who we cared for in the clinic, and just even the small sample I showed you, had CRPS for many, many years. And I think part of that is because it's just underdiagnosed and goes unrecognized. And so many, I don't want to say most, but many of the patients who I see have already had CRPS for years and years. So I do think that there is some potential. You know, I'm very like optimistic, and so I like to always think that there are some other options that again integrate different multidisciplinary approaches. And so there's a question about vitamin C prophylaxis. Yeah, I mean, a lot of our surgeons now will start to recommend vitamin C very quickly after an injury. So I think that is sort of out there, but it definitely could be more protocolized. So I think that's actually a really good question. So there's just a few questions about like diagnosing nerve injury. It really depends on where the nerve injury is. So some nerves are just too small and cannot be visualized. Like I have a lot of patients who come in with like post-mastectomy pain, and the nerves that run along the ribs are just really teeny tiny. And so a lot of times, and there's too much bone. And so that affects the way that the scans look. And so it's not always possible to really get a specific nerve diagnosis with this neurography approach. But more and more pain physicians are very good with ultrasound. And so for nerves that can't be imaged with neurography, ultrasound evaluation of small, hard to reach nerves is sometimes possible. So I think that's also something to think about. So someone's asking about zoledronate. So zoledronate is like a really long-acting version of bisphosphonates. It has not been particularly studied that I know. They're all about the same though. Like all the data were essentially the same from all of those different bisphosphonate studies, except that one study that failed, and I don't even think they published it. So I kind of consider them all about the same. The difference is that zoledronate is IV, and I can't, as a pain physician, I don't have access to use IV bisphosphonates, which is why I've sort of I lean towards the oral medication. Yeah, and I'm so sorry. You know what? I cut my slides off right before the graded motor imagery slide, and so now there's a question about it. I do think graded motor imagery is actually very useful. The data supporting it are kind of moderate, just like everything. I mean, this is not a hugely studied condition. It's not that common, but graded motor imagery, which is essentially like doing different imagined movements, looking at laterality of in images, things like that, that basically are brain training for CRPS, I think is very helpful. And so finding a physical therapist, I've said like physical therapy and hand therapy is really important. Finding a PT or an OT who knows what CRPS is and can do graded motor imagery, I think is really helpful. Ketamine cream. So any cream gets into the bloodstream at a very low level. So we really consider it essentially negligible in terms of its transfer to the bloodstream. It's some amount, but it's very small if you're using it in the recommended amounts. You know, if you put it over your whole body every hour, obviously it would potentially put higher levels in your bloodstream. But if you're using it limited to where it's supposed to be a few times a day, it shouldn't be an issue. And then there's just some questions about underlying conditions causing CRPS. It really depends. You know, I'm a bit of a CRPS purist in that I tend to think of it more as like a post-injury response, but there are these like mimic conditions where I talked about autoimmunity at the end. So like this potential of the body attacking itself. And there are things that can trigger really aggressive autoimmunity. And somebody's example or question was psoriasis. And so that is something that can trigger autoimmunity and thereby maybe trigger a CRPS-like reaction. So whether it's exactly CRPS or something like CRPS, it may present very similarly. And so it is possible. Okay, I'm sorry, I know we're out of time, but I wanted to, so somebody asked about gabapentin or antineuropathics. I did not talk about them because, yeah, they're used for many different types of pain. And I was trying to really focus my comments on things that are more mechanistically CRPS treatments. But absolutely, I use antineuropathics all the time, including tricyclic antidepressants, you know, gabapentinoids, et cetera. So absolutely. So I think maybe I will stop there and pass it back to James.
Thank you, Dr. Tawfik. I think you made that very complicated syndrome less complicated for many of us. So thank you. And then thank you to the audience for joining us tonight and for the great questions that you have submitted. If you would like additional information or resources, please contact our Stanford Health Library. We hope you'll join us for our next lecture. Thank you and good night.